Hello, everyone, and welcome to the Solve Wellness webinar, Hormone Therapy in Genitourinary Syndrome of Menopause, Reframing Risk, Rethinking Practice. I am Aaron, your host. So that's it for me for now. I'll turn things over to our moderator for the hour, Dr. Melissa Kaufman and team. So Melissa and company, welcome to the virtual stage. And Melissa, I hand it over to you.
Thank you so much, Aaron, and thanks to everyone who is in attendance tonight. We really do hope that this is going to be about rethinking your practice for GSM. I wanted to introduce this really esteemed panel. To start off, Dr. Rachel Rubin, who is a fellowship-trained sexual medicine specialist. She's actually the director at large of the International Society for the Study of Women's Sexual Health, and just a nationally recognized educator, contributor, and has done many, many different programs and has been one of the biggest advocates for women's sexual health and for genitourinary syndrome of menopause. We also have Dr. Flynn, Dr. Brian Flynn. He is a professor of surgery and urology and founder and fellowship director of functional and reconstructive urology at the University of Colorado. He has a very distinguished career spanning over 2 decades and is a really recognized leader in reconstructive urology and quality of life conditions, of which GSM is a major contributor. He'll be weighing in quite a bit on the genitourinary aspects of GSM. And then we have Dr. Gina Northington, who's a professor of gynecology and obstetrics at Emory University. She's director of the Division of Urogynecology and Reconstructive Pelvic Surgery and is actually on the board of directors of the American Urogynecologic Society and the board of Obstetrics and Gynecology. So thank you everyone for your engagement. And here we also have in the background, but not such background, Seth Cohen, who's assistant professor at the City of Hope, a very renowned functional and reconstructive urologist. He's the program director there of the Cancer Survivorship Program and the Reconstructive Urology Fellowship. So I want you as an audience to utilize this brain trust that we have assembled here for you and ask lots of questions. And we hope that many of the questions that were pre-submitted, you will have an opportunity to have answers to tonight. We have a few disclosures, but most have no applicable disclosures. And we really want to acknowledge the bold move by the American Urological Association to publish these guidelines on the genitourinary syndrome of menopause. This has really been transformational, both for the society and hopefully for all of our patients. And I want to give some deep gratitude to Kevin and Terry Wade from Solve Wellness for their decades of innovation, which has really been dedicated to advancing care for our patients. And this is evidenced by both their service and their sponsorship of this type of initiative. So thank you very much, Kevin and Terry and Solve Wellness. But mostly, we thank you, your engagement, your dedication to these patients that have often been traditionally very marginalized in our healthcare system, and to take this opportunity to really learn and advance care for all of us. So I wanted to just give a little bit of background before we get started on these guidelines on GSM. And you can all access them here. They're available at the auanet.org, but this is also the QR code for direct access to all the guidelines. And there's 26 of them. And they go through shared decision-making, screening, diagnosis, all the hormonal and non-hormonal interventions, energy-based interventions, breast, endometrial cancer, surveillance, and follow-up. And I would like to say as well, like, although there's 3 members of this panel who serve directly as guideline panelists, we're not exactly speaking for the guidelines. We're going to use them to frame this discussion, but these are our own opinions. So what is GSM? Really, this terminology was established just in 2014, and it was a consensus panel between NAMS and ISWISH that really was meant to improve medical accuracy and public acceptance, and not use a whole suite of terms such as atrophy, which is a good description for what some of the physical exam findings are, but it was really to encompass what this entire syndrome and group of symptoms may be. It was really meant to open the conversation and decrease social stigma. And it really is a broad array of signs and symptoms that include dryness, burning, irritation, dyspareunia, and a whole suite of different urinary dysfunctions as well, including recurrent urinary tract infections, which involves all the structures around the labia, the vestibule, the vagina, the urethra, and it's associated with imbalances in not just estrogens, but sex steroids. And how common is this? I don't think we'd be talking about it if we didn't know this was extremely common. Up to 87% of postmenopausal women, but it's not just postmenopausal women. It's perimenopausal women. It's women on systemic estrogen. It's women who've undergone other treatments for cancer. It's women on oral contraceptives or who are breastfeeding or on hormonal suppression for other causes. So really you have to broaden your perspective as to who would be a candidate for many of the treatments that we're going to describe. And it's because estrogen is a dominant regulator of this physiology and testosterone. And so all these tissues in the vagina, the squamous epithelium, they really change in a low estrogen environment. And you get a loss of the fornix, you get thinning of the walls, reduced blood flow, decreased length, atrophy of the labia, and narrowing of the introitus and the entire vagina. And so I'm going to do this with case bases. Oh, look, this is Mrs. S. She's 77. She looks really, really good for 77, doesn't she? AI is magic. She comes into you. It's a really typical patient. Maybe your patients don't look quite as good, but she's a really typical patient. Comes in with recurrent urinary tract infections. She has frequency, urgency, vaginal complaints of dryness and irritation, a pretty typical but benign past medical history. She did have a maternal grandmother who had breast cancer at age 86. And so what should happen first off? Well, we can talk a little bit about this, but one of the things that the panel believed was the patient should undergo a genitourinary exam. Now, how you do this, when you do this, can certainly be up to debate in a lot of ways, but in general, what is an appropriate exam? This is a physical exam, but it is one that is done with trauma-informed care. Many of these women who will come to you have not had exams for decades of time. They may be very uncomfortable with the thought of this. They may not have anticipated it. So your messaging about how this is done and in what context it's done is very important. It's really a gentle visual inspection. You're looking for the signs of pale, fragile epithelium, thinning, erythema, all the things that we typically considered for vaginal atrophy are really reflective of genitourinary syndrome of menopause. And in general, some of our best management options, and we're going to launch right into it, have to do with supplementing estrogen to the vaginal tissue. And so very early on, one of the high statements was that clinicians should offer an option of low dose vaginal estrogen in patients with GSM to improve a number of these symptoms. It comes with very strong evidence. But we're going to get into a lot of the details. Many of your pre-questions were about the details of how we message about vaginal estrogen, how we utilize it, which patients are appropriate for, and what other conditions are associated. So I'm going to turn over now to part of the panel, and we're going to go through a lightning perspective. And the first lightning that we've got is one of the ones that, of course, strikes all of us, and that's Dr. Rachel Rubin, who's going to discuss not only utilization of vaginal estrogen, but a lot about safety as well. Rachel?
Oh my goodness, what an introduction. And I would be remiss if I didn't just say thank you to Dr. Melissa Kaufman, who is our fearless leader. My friends, Dr. Kaufman chaired with Dr. Una Lee, the guidelines committee for this just incredible document that words can't even describe how proud I am of this group's multidisciplinary effort in putting together what is a clear, concise, and truly beautiful document that will and is already saving lives and changing policy at the highest levels. And so, some of you follow me on social media. If you don't, you should, not because I want more followers, but because messaging matters here. And I think what Dr. Kaufman and I do so well together is she changes the world from the inside and I poke from the outside. And it really has been just an incredible year for us to pull off these guidelines and then get on every soapbox that we can find to teach them, because it is not enough that these guidelines are written, although they are so excellent and it is important that they are written, but we must get these prescriptions and how to write the prescriptions and why the prescriptions need to be written in the hands of every clinician who takes care of women, regardless of subspecialty. And so it just really is and thank you to our hosts for this awesome evening, because our industry partners really also help us get the megaphone out. And if you know me, I will talk on every soapbox that I can find. And so we talk a lot about different formulations. You have choice here, and sometimes choice can be overwhelming of, oh my gosh, there are so many options. And I get this on Instagram all the time, but what's the best option, Dr. Rubin? What is the best option? And I think the best option is the one that your patient will use till death does she part, that she can afford, that it doesn't drive her crazy, that she remembers to use forever. And so for many patients, that's going to be your estradiol creams. It's the cheapest, right? You can get it on Cost Plus Drugs or GoodRx for, anywhere between $13 a tube or $30 a tube, and it's often well covered by insurance. You can teach your patients to rub it into the walls so that it's not messy or goopy. But many women still don't like to put creams on. I tend to move beyond the conjugated estrogen creams, although because they're still, they're not generic and they're rather expensive. But the creams can work. So I encourage you, if you only prescribe creams, to start to use the estradiol, the more a non-synthetic cream. And then I'd also recommend you start learning some of these other options that we have for patients. I often will use estradiol 10 microgram inserts. There's a generic called Uvafem. The trade name is Vagifem. They can use it twice weekly. Every ER doctor can write the prescription, estradiol 10 micrograms, insert twice weekly till death do you part. Don't wait to go see, to wait 8 weeks till you get in with your gynecologist, or 8 months if you're in our area. Start right away, because this is life and death medicine. Now, we have some nuance here. We've got rings that can stay in for 3 months at a time. We have vaginal DHEA, which is, Dr. Kaufman made a few comments there that she sounded like it was just, routine, a thing. She said some revolutionary things that are just actually just medicine changing. The first thing she said was that this tissue is androgen dependent. It is not just an estrogen story, but that there are testosterone receptors in this tissue. And that is, I think, changes the fact that the AUA came out and said that very clearly, sort of changes the world here. And so intra-rosa or vaginal DHEA is the only FDA approved option we have that actually adds some androgen to the tissue. Now, we can go through all of the nitty-gritty nuances of each of these products, but I know you have lots of other questions. And so happy to answer sort of when we use one or the other, but just start with one. If it's a cream, start with a cream. Do a gram twice a week. Just make it simple. If it's the inserts, 10 micrograms twice a week, make it simple. Anybody, guys, you guys, anybody can do this. Truly, anybody can write this prescription if you take care of a woman. I have plastic surgeons writing for it, rheumatologists, ID doctors, ER doctors. It's truly revolutionary and quite easy to do. But there's a fear going on right now. There's the people go home and they look at the box and it says in big bold letters, this is going to cause stroke, heart attack, blood clots, probable dementia, and cancer, and you must take progestin with it. My friends, we are in crazy town. All of this is not based on any actual data. Zero. I've checked. The guidelines committee went through all of the data. There is no data to substantiate this inappropriate labeling that was put on all estrogen products, whether it was an oral synthetic estrogen or a topical low dose estrogen. This warning label was placed on all products. And we have since been very loudly advocating. And for the first time in the world, the head of the FDA has said he wants to look at this and actually potentially make some changes, which is, again, the guidelines helped us get into that door, which is just so miraculous. And so we're going to pause here. I think Dr. Kaufman has a question for all of you.
Yeah, let's do an audience question. So everybody go ahead, and you're going to get the results brought up here, and everybody make your choice about the 77-year-old who wants to discuss the product labeling. She comes back to your clinic like, what's your next move? What's your next step for this patient? Are you going to go ahead and do a biopsy, or switch to lasers, or switch to DHEA, or get a mammogram? For by and large, 98% said reassurance and continuation of vaginal estrogen. What do you think, Rachel?
So I think it's absolutely right. You should not pass go. You should not. You must highly consider vaginal hormone therapy. This is the path. Now, vaginal estrogen versus DHEA. Honestly, that's a little bit of a trick in that they're both good. They're both great options, and the patient would do great with either of these options. Now, I will say sometimes estrogen is a little bit easier to get for your patient than the DHEA. We find that sometimes there are challenges with prior authorizations and things like that.
Rachel, Dr. Rubin, quick question from audience for you. Is
Yeah.
there any, this is Seth again, is there any specific terminology you put into your documentation in the electronic health record for the consenting process when you're prescribing people topical estrogen cream?
It might sound like Dr. Cohen, but I think it might be God that is speaking with us. We're so glad to have him here. This is where it's, I think it's reasonable to write in your documentation, what GSM is, what the guidelines say, that you spoke with the patient about the box labeling. But the reality is the guidelines are behind you, in the sense that not only are the guidelines behind you, but the head of the FDA has been publicly stated that these labelings are not correct. So if it's a medical legal thing, sure, put a little dot phrase. The more important thing is actually talking to your patient about the box labeling, because if she does not use this product, she could die of a urinary tract infections and urosepsis. So for me, I worry less about the medical legal and more about the making sure I scare my patient into deeply understanding the benefits of this product and sort of the false labeling that exists. So again, this is where clips, social media, blog posts, guidelines really help you. We lobby to the FDA, and you can listen to me for 5 minutes, sort of talk about the guidelines, my story, why we must change the labeling, and a patient can understand that. So use all of the, this is why we do it, not because we want to be popular, but because we want to give you tools, because sometimes a 10-minute visit is really hard to explain the full extent of the nightmare that is this box labeling that we're navigating.
Thank you.
Perfect. And in fact, we do have guidelines that say you should inform patients of an absence of evidence linking low-dose vaginal estrogen to the development of breast cancer. And of course, it was backed up by very high-level evidence that we can reassure there's no data that is associated with increased risks of breast cancer. So you can reassure regarding the safety of treatment. And indeed, there's actually a small decrease in mortality in this very large study in patients that utilize vaginal estrogen after treatment. But tell me more a little bit about this FDA initiative, Dr.
Yeah,
Rubin.
we have more data to show that there's mortality benefit when you use vaginal estrogen, whether it's through we have data about decreased stroke and heart attack risk on people on vaginal estrogen, decreased, like, breast cancer patient died less when they used vaginal estrogen. And it really comes to this idea that we know the UTI risk and the sepsis risk. We published on the fact that we could save Medicare billions of dollars a year if we just use vaginal hormones, because all those visits that people are coming in for cultures, for UTI visits, for sepsis visits. So back in July, this is a really big deal, and I need everyone everyone to get your phones out. I don't ask a lot of you. I do sometimes, but this one's really important. You have until midnight tonight to have your voices heard. In July, we were invited, a panel of us were invited to the FDA by the head of the FDA himself and said, we must look at this, and we don't think this labeling is correct, and we want to hear from people. And so I got to sit. I would love for you to watch my testimony, but I want you, your voices, your clinics, my friends, the American Urologic Association, OGS, SUFU, ACOG, everyone, the Menopause Society, everyone is writing statements in support of the removal of this labeling. It's not politics. This is I'm in DC. We do a lot of politics here, but this is truly a bipartisan effort that is so helpful for women. And so everybody go to that QR code, and you have till midnight tonight just to write how you feel and tell your story. If you're a clinician, how this box is really makes it challenging for you to do your job correctly.
Perfect. Thank you so much, everybody. Get your phones out. And of course, 11:59 tonight. What about patients, though, on systemic estrogens? We get a ton of questions about this. Like, what do you tell them? Shouldn't they already be supplemented?
So I will tell you that guideline statement 11 is actually, I'm a nerd for this stuff, and guideline 11 is my favorite statement of all of the statements because I prescribe a ton of systemic hormone therapy. It is one of the most joyful things I do. I love teaching how to prescribe systemic hormone therapy. And there is this disconnect between people who prescribe patches and oral estrogen or even pellets and their willingness to add vaginal hormones to the routine. And I'm here to say, do it. Always screen for urinary frequency, urgency, dryness, pain with intercourse, or urinary tract infections. And it's not adding any danger to the systemic therapy. So if you're using a patch to prevent osteoporosis or to help with hot flashes, they may still have overactive bladder. And you're going to hear all about the benefits of these amazing therapies for overactive bladder. And so I encourage you, and if you know people that you love that are on hormone therapy, they may not be on vaginal hormone therapy. And so I really think it's important. And now you have a guideline statement behind you, which I love so very much.
And if you could just touch a little bit, you mentioned on that guideline, if you could just touch a little bit about testosterone and utilization of testosterone for GSM symptoms.
Yeah, this is very exciting because the AUA, again, it's truly monumental what the AUA has done. I've never been so proud to be a urologist and really say that GSM is a urologic condition, right? This is urology, urogynecology. This is a multidisciplinary problem that everyone who takes care of women should be caring about. And now we get to start the conversation about testosterone and how testosterone plays a role in the health of this tissue. Now, right now, we only have FDA approved DHEA, which is the precursor to estrogen and testosterone. And so if you have a patient who's on the right dose of vaginal estrogen, but they still have urgency or they still have dyspareunia, you may consider switching them to a vaginal DHEA. And so I would love to see the explosion of new research on testosterone therapy for GSM because we need a whole lot more of it. And so for all of you listening who are researchers, we need you in this. We need you to kind of roll up your sleeves and help us do the work here, because I think we're going to see a lot of alternative therapies that we can use for GSM in years to come. So I think this is really only the beginning.
Thank you so much. And speaking of urologic conditions, I'm going to give this lightning perspective takeaway to Dr. Flynn. And I'm going to give you another case, Dr. Flynn. This is Mrs. W. She's 66. She looks pretty good for 66. But she's coming to you with vaginal pain and dyspareunia, but she has urgency, incontinence, dysuria. You did an evaluation, her UA is negative. She has a normal PVR. Let's ask the audience. We got another poll question. Let's ask the audience, like, what GSM consequences do you most encounter in your practice? So go ahead and use your radio buttons and let us know.
Melissa, what are we seeing?
We're seeing a lot of recurrent urinary tract infection, sexual dysfunction, and overactive bladder. What do you think, Dr. Flynn? What about all these other urologic conditions?
Yeah, this is spot on, and this was my day today. So thank you, Dr. Kaufman. And I'm just excited to be here. I feel very honored to be with these experts. three tremendous experts that, wrote the guidelines. I wasn't on the guidelines, and I'll admit this wasn't even on my radar. I'm a functional urologist. I do a lot of reconstructive surgery. Been doing this for 25 years. And I have to admit, there was some reluctance for me to really have these conversations. We're all so busy. The patient was referred to me for overactive bladder. That's pretty clear. That's the history and that's the focus. Here's your beta 3 agonist, and come back. If that doesn't work, we'll discuss tier 3 therapies. And I feel like by the advocacy that the three of you have done, Kelly Casperson and others, friends, my former residents, my current fellows, really, made me very aware that, there's one drug I might be able to prescribe for this patient to cure two problems, and that would be vaginal estrogen. And so I think that poll question is interesting because it depends, who's answering it. I think if you're a urologist, especially in the community, it's recurrent UTI, it's overactive bladder. But maybe if you're a urogyn or gyn or in an HRT practice, it might be something very different. So I think we all, have certain tools in our toolbox, and we have to kind of think more broad and perform a physical examination. Maybe start out with that, Dr. Kaufman. What does a physical examination look like? I see the residual, I see the UA. So right now, I'm thinking about three things: overactive bladder, recurrent UTI, or I'm thinking about GSM.
Yeah, and of course, her physical exam, as we see in all of our guidelines this is the genitourinary syndrome of menopause, right? And all our guidelines for recurrent UTI, for overactive bladder, and for GSM do mandate an exam to be done so we can make sure that we've ruled out other bothersome causes. And her exam was fairly typical for what you might see, with a lot of thinning of the epithelium, a lot of erythema, some retraction of her actual meatus. And so you could be fairly confident there was nothing else, but she has GSM.
Okay, thank you. And I encourage those to do exams. A lot of practices, people have to come back for an exam. It has to be scheduled, it has to be part of the appointment. You can't just do an exam on the fly. For me, I need a chaperone every single exam. And, we have to be prepared and ready for that. We are on our new patients, but not always on the return patients. But I think it's very important to not hand them a prescription and miss a big diagnosis: bladder cancer, severe prolapse, urethral diverticulum, all of these things, eroded mesh, that we really need to be thinking about if we're going to be good stewards for pelvic health. So for me right now, I see these symptoms. I talk to them that I want to provide some treatment in the here and now, and that would be with the beta 3 agonist. That's going to have the quickest onset of action with 3 and 5 days. But I also talk to them about vaginal estrogen, and start slow and start low and give it some time. Load them up over the next few weeks and then see them back. And potentially I might be able to wean them off the beta 3 at some point if they're doing well on vaginal estrogen alone. So that would be my approach. I don't think they need a cystoscopy. The guidelines certainly don't support that. So the workup is pretty light. I think this is something that any of us really should be able to be capable of doing, and certainly advanced practice providers can do. If you're too busy in your practice, find someone who's not, or hire someone who can really help, with this large population that needs attention.
Yeah, and our guidelines would certainly support that, particularly with recurrent urinary tract infections, that they actually reflect the recurrent urinary tract infection guidelines to recommend low-dose vaginal estrogen. And for the first time, as you mentioned, they reflect the fact that for other conditions like overactive bladder, offering the option of low-dose vaginal estrogen is really important for GU symptoms. So we're going to come back to your patient in a minute, right? She's coming back. Don't you worry.
Thank you.
Mrs. J. But in the meantime, we're going to get some lightning perspective from another patient. And we're going to bring in Gina here to talk about other types of maybe non-hormonal interventions. Because there was a good suite of information that was produced in the guidelines about this, and a major question that many people have. So I've got another case for you, Gina. This is Mrs. W. She's 63, so we're getting a little bit more realistic here. She has vaginal burning, chronic dysuria, but she does have a past history. You did a prolapse repair on her a few years ago. She's doing great from that. It looks really good too. But she did have a history of breast cancer, and she finished a selective estrogen receptor modulator treatment about a year ago. And she comes to you, and despite listening to all of Dr. Rubin's social media, she still is interested in a trial of some type of non-hormonal treatment. So why don't we ask the audience? Let's pull up another audience question here. So audience, what are you going to do with this patient? You know, she's coming in. What option may be appropriate for first line application? You're going to send her off to PT. You're going to tell her to change positions. You're going to give her some testosterone pellets or Botox. What else are you going to use? So most people chose vaginal moisturizers. What, Gina, can you give us some insight into that?
Sure.
Thanks.
Sure. Well, first of all, I just want to thank you, Melissa, and Dr. Lee for your leadership in getting these guidelines together. I really echo what Rachel has said. This is long overdue. I am a urogynecologist, and I've dedicated my career to caring for, primarily female patients who have pelvic floor disorders, including urinary incontinence, overactive bladder, recurrent urinary tract infections, sexual dysfunction, pelvic organ prolapse, and defecatory dysfunction. And I have to say that vaginal estrogen is quite the mainstay of my armamentarium that I am offering really to women that fall in that whole spectrum of diagnosis. But you're right, Melissa, we do get patients for one reason or another who say, you know what, I keep those hormones away from me. And by the way, I wish I could get my patients to listen to Dr. Rubin. Then I would do a lot less convincing myself. They would come in asking for it. But yeah, they come in and they want some alternatives, and vaginal moisturizers are a great alternative to vaginal estrogen, at least, especially if she's suffering with this kind of burning and dryness and dyspareunia. There is some evidence of effect for vaginal moisturizers. And I want to just take a minute to try and contrast vaginal moisturizers with lubricants. So vaginal moisturizers, there are various ones on the market. You see a brand here from Solve Wellness, Via, and there are others on the market, and they have different ingredients in them. But what they try to do is really kind of replicate the natural vaginal moisture and adjust the pH of the vagina. Even though we don't have a lot of evidence, that pH adjustment might actually be of some benefit in helping with urinary tract infection prevention as well. And there has been some data to support that vaginal dryness and dyspareunia can improve with these moisturizers. Lubricants, on the other hand, these tend to be more like silicone-based products or oil-based products that really work for a short period of time in helping reduce friction. So they might be really useful for an episode of sexual intercourse where there's a great deal of friction. But I would actually advocate, if we're going to use lubricants, to also use the vaginal moisturizer on a daily basis. I typically will get more benefit with the combined therapy in patients that elect to utilize these.
How about using the moisturizers with the estrogen? How do you counsel patients about doing that?
It's completely reasonable. Sometimes I have patients, for instance, my breast cancer patients who might be on the 10 microgram tablets of vaginal estrogen and still might not have quite the effect that I'm hoping for, and they are reticent about going up on that dose of local vaginal estrogen therapy. And so I find moisturizers useful as an adjunct in that case. And so I've done that as well.
Yeah, but she looked on social media and she pushed past Dr. Rubin's site, but she found some stuff about laser therapy, right? So, I mean, what about lasers? Because this patient really, she said, "I want you to rejuvenate my vagina." And this was what it said the lasers would do. What do you tell these patients? Hey,
Well,
why don't we ask the audience? Let's ask the audience what they
let's see
tell
what the
us.
audience says.
Before we get to you, why don't we ask the audience? So what are you guys going to do? Here's this patient. She comes in and she's seen all this information about lasers for use for vaginal rejuvenation. Like, is that okay? Or is it approved? Is the CO2 laser approved? Are they always covered by insurance? What do we tell our patients about this? Overall, it's true. Although the data is limited, some women may really prefer laser treatment, right? And do our guidelines support that?
No, in fact, what our guidelines say is that there really isn't any evidence to support the use of any of the currently manufactured laser type products, whether it's CO2, YAG laser, or radio frequency. And so we really just don't have that. Certainly, I have recalled reading some very short-term, often single-arm studies that did show an improvement with the use of these lasers. But those, when we looked at it as a guideline panel, we really didn't feel that those studies really rose to the level where we could make those recommendations. And currently they're not FDA approved. They really haven't reached the bar that the FDA has set in terms of efficacy and safety. That being said, it is in the armamentarium, just like, vaginal moisturizer products aren't necessarily FDA approved. It still may be of benefit to patients who can't or don't want to, for whatever reason, to use a hormonal based product. And so, we talk about this shared decision making where we keep really our patients at the center of this process. We take into account their preferences and what their quality of life is and what their lifestyle is. And, this might be something that might be right for her. And we can talk about this absence of evidence and, what the patient should be thinking about and what, some of the adverse effects could be. And then let her make that decision.
Gina, the other really critical question that we get quite frequently is about concern for endometrial cancer. And I think you're the perfect person to kind of bring forth the data that we found in the guidelines about this. What do we tell patients about development of endometrial cancer and use of vaginal estrogens?
Absolutely. And thank you for that question, Melissa, because we really have absolutely no evidence, even with decades of studying local vaginal estrogen, that there is an increased risk of endometrial or breast cancer for that matter. So I definitely counsel my patients that I would not be concerned about, even with long-term use of low-dose vaginal estrogen for endometrial cancer. Some of the studies have shown in a small group of the treatment arm that there can be some episodes of endometrial hyperplasia. We don't know if that's cause and effect, but there has been no cases of endometrial hyperplasia with atypia, which is considered more of a precancer, or endometrial carcinoma. So I am very comfortable. I've used this for over 20 years in my practice. Many of my patients have been on it for long term who have a uterus, and I'm very comfortable with that. These patients, unlike with systemic hormone replacement, these patients don't require any kind of progesterone type supplementation to protect the endometrium. In fact, you may introduce other risks that are not necessary. And so I'm very comfortable in that recommendation that we've arrived at.
Gina, what about actual patients on treatment for endometrial or ovarian cancer or recently treated for endometrial or ovarian cancer?
That's a great question, Seth. Thank you for that. Some GYN cancers you can safely use vaginal estrogen without concern of cancer recurrence. And those cancers include ovarian cancer. Ovarian cancer is not an estrogen-sensitive cancer. I mean, you know, so I have no issues with that. Cervical cancer is also not an estrogen-sensitive cancer. Cervical cancer almost exclusively occurs because of the human papillomavirus, HPV, which is why we have a really great and effective vaccine now for that, and are starting to see cervical cancer rates plummet. So those two cancers are not a concern. And in fact, my cervical cancer patients who have undergone radiation therapy, absolutely the first thing we do is start them on vaginal estrogen. So that's very important. Endometrial cancer is another story. So endometrial cancer, if you have endometrial cancer and you're in active treatment, it's absolutely a contraindication. So I wouldn't give it, because the vaginal estrogen, even in those who've had hysterectomies because of endometrial cancer, the vaginal estrogen is getting to the cuff. Now, we do not have evidence of endometrial cancer recurrence with vaginal estrogen, but out of an abundance of caution, I tend to counsel against that, because the number one place of endometrial cancer recurrence could be at the vaginal cuff, and that vaginal estrogen will, of course, touch that. Now, patients remote from early stage endometrial cancer really have a baseline risk, right? So they are remote, they had early stage without spread, they didn't require radiation. And so those patients with, again, that shared decision-making, who, they're 10, 15 years from their diagnosis, suffering from genitourinary syndrome and menopause, there really is no evidence of an increased risk of a recurrence. And I think you can feel quite comfortable with low-dose vaginal estrogen in that group.
Thank you so much, Gina. We're back to you, Brian. Lightning perspectives. We're going to bring back Mrs. W. I told you she was coming back to see you again, because you gave her the vaginal estrogen, you gave her the daily moisturizer, you gave her the beta-3. Good job. She had an excellent response. She did so good. She came back and she said, I feel like a teenager again. I feel so good. Right? So what happened? She comes back in 6 months and every symptom has recurred, every one of them, because she said, you cured me. So I stopped all my therapy. Right? So it really brings up, like, how do you counsel patients about what is appropriate follow-up for GSM and the symptoms associated?
Yeah, thank you, Melissa. And I'm glad that we made a difference with that triple drug regimen. And I think you need to get to why she stopped. A lot of times it's finances. Things can be expensive, especially beta-3s. I saw that brought up in the chat, that beta-3s, they can't get covered for the patient. Now that we have mirabegron, which is generic mirabetrol, it's gotten slightly better, but not much better. With Gemtesa still branded, it can be challenging. So you need to get to the why. Other times it's just hesitancy, like, this is an infection. You treated it, I got better. I don't really need to take it. So you really need to emphasize to the patient, this is for life. This is like taking a vitamin or a supplement. And when you stop it, you'll have a recurrence of your symptoms. Why wouldn't you? And trying to really help them understand why they got better. So maybe the compromise might be 2 of the 3, and I'd probably drop the beta-3 off because it'd have the most side effects and expense, and maybe they'd be more willing to take 2. But it requires a lot of counseling, a lot of coaching, a lot of encouragement, constant reinforcement. I think you're obligated to see them back at least once to see where they're at. If you see them back, typically for me, it would be about 3 months. I think that's enough time. I'm very, diligent on moving people to the next step, whether that's a tier 3 therapy for OAB or maybe adding some other regimen, and really trying to revisit the symptoms. Maybe it's time to do some diagnostic work if they hadn't improved. This patient got better. She stopped. She just needs to get back on her treatment.
I agree. And we discussed this as a guideline panel too, that these patients may need long-term follow-up and that it's a long-term treatment options as Dr. Rubin says, till death do us part with your vaginal estrogen, right? Because these signs and symptoms, not only is it about managing the treatments, but their signs and symptoms can change as their other medical comorbidities evolve as well. So we're going to leave some time because we've got lots and lots of questions in the chat, but I just wanted to make a few conclusions. This is a very prevalent condition. It's a diagnosis of symptoms plus the signs on a physical exam. I wish I could give you more time in your clinic to do those exams. And we struggle with this. Everyone struggles with this because it is a time sensitive. It's a little different than doing a PSA follow-up in many cases. But it's often comorbid with a lot of other common urologic conditions. And our mainstay of treatment really is low-dose vaginal estrogen. And we offer this even to women who are on systemic estrogens. We do have safety profiles for breast cancer, and ongoing therapy is often indicated. And I think that there's a lot of discussion here that's just going to bring up a tremendous amount of research that needs to be done. This is one of the things that truly was brought out in our guidelines, is that there is very little high-level evidence that's actually comparator that does comparative effectiveness between treatments and sometimes non-treatments that can give us great guidance. And so a lot of this is a multidisciplinary shared decision-making process where we bring in all the stakeholders, and that may be their gynecologic oncologist, it may be their primary care physician, it may be their other urology team that we bring in to have this discussion as a group to come up with the best consensus. But the most important individual in this whole thing is the patient, right? It's shared decision making. We have to look at their values and preferences, and sometimes that means taking a risk when their symptoms are so profound. So only those who seek are going to find, and we really thank you for seeking. This is, again, the QR code for the guidelines panel, for the GSM guidelines. And we also, again, encourage weighing in on to the FDA about utilization of this therapy in a much broader perspective by reducing the burden to women with the product labeling. So, Seth, I'm going to turn it over to you.
Sure.
Because there's lots of questions that the panel can then help answer.
A lot of great questions. So to go back to there's a lot of citations on here. And you kind of alluded to this, Melissa, about estrogen driving ovarian cancer populations. And I work at a cancer institution myself. And I guess I would say on these citations, I wonder how much of this is actually looking at vaginal estrogen. I'm going to guess not much, because vaginal estrogen absorption is so minimally absorbed systemically. But I would just echo what Melissa said in terms of really working multidisciplinary. All the decisions made for patients on cancer treatment or recently finished cancer treatment, I make with the gynecologic oncology and medical oncology teams. So appreciate all those citations. Absolutely needs to be a shared decision-making process and in cohort and concert with the multidisciplinary team. There's another specific question about a cancer population. So going back specifically to anastrozole and letrozole. So if a patient is on anastrozole or letrozole, there's a concern that the oncologist would definitely say no to any vaginal hormone therapy. And what does the panel have to say to that?
I'll just jump in, Seth, if that's okay, Melissa. Agree with Seth. When I'm working with my GYN oncology patients, my GYN oncologist is right next door to me, and so we work together. And she's very well versed on the literature, and there's no literature to support that vaginal estrogen will increase the risk of ovarian cancer recurrence or spread. Same thing with cervical cancer as well. But there's estrogen receptors in all kinds of GYN cancers because these tissues have estrogen receptors on them. So I appreciate the references. That being said, as far as inostrotol and letrozole, these drugs, that they're designed to minimize, is to bottom out the serum estradiol level. So if there's even the slightest bit of absorption, the concern is that, your estrogen, that slight little bump in estrogen level that you might get, even though it's still in in the postmenopausal levels, it's not low enough for what they're trying to achieve. And so there are medical oncologists that will say no to that. And so I work with the patient and their oncologist, and, we look for our alternatives like the vaginal moisturizers and things of that nature. There is also, evidence that we talk about in the guidelines too about the 10 microgram tablets. The 10 microgram tablets are an ultra low dose of estradiol. And there's been a few studies that have looked at the serum levels without seeing an increase in the serum levels pre versus post. And so, sometimes with the oncologist involved and the patient at the center, we will use a very ultra low dose vaginal tablet that's 10 micrograms or less. They come also in 4 micrograms as well. So that's also an alternative.
Very good. Thank you. Rachel, question for you. So someone is asking, what is the difference, functional difference between oral versus vaginal DHEA in the treatment of GSM?
That's a great question. And they're completely different in that we have tons of data for if you take DHEA and you use it vaginally, that it acidifies the tissue, that it helps with pain with intercourse, lubrication, dryness, and we publish that it prevents urinary tract infections, similarly to the way vaginal estrogen does. The data on oral DHEA is sort of all over the map, and our guidelines didn't really look at oral DHEA, and it has, as far as I know, there's no data on oral DHEA for GSM management. And so whether or not oral DHEA helps with any forms of increasing testosterone or libido or sexual function, that data is not very, we don't really have a consensus on oral DHEA, but we have very good consensus on vaginal DHEA. And so I use the FDA approved product, which is called Intrarosa. It's a 6.5 milligram insert. What I also love about it is not that it's just the only androgen available, but that it's just DHEA and palm oil. So it is kind of moisturizing in and of itself. So it can be a lovely, lovely product as well. And remember, you will get this question all the time. It will not hurt the penis, my friends. The vaginal estrogen, the tablets, the suppositories, a male estrogen level is 25 picograms per milliliter. Okay. Vaginal estrogen and DHEA do not raise systemic levels of estrogen. It will not absorb through the skin of the penis and cause any side effects to the poor partner. Please tell your patients that because they will ask. And that's actually part of why we created a YouTube channel to every question because the more I put out content on this very simple topic, we get hundreds and hundreds of questions over and over again. And I don't know about you, but the four of us are feeling like broken records where we say the same thing many, many times a day, which is actually where social media can be game changing. Because they don't want to just listen to you. They want to listen to the four of us and they want to listen to another. So, they want to listen to other people because it makes them realize like, okay, maybe that box labeling isn't so scary.
Excellent. Thank you very much. So a busy urology allied health professional only is given 10 minutes per patient per day, really wants to engage with pelvic exams and prove their worth in the treatment plan. How do you do that? How do you make that functional in a busy urological practice doing a pelvic exam? I'll open it up. Gina, Rachel, Melissa Kaufman.
We all struggle with this. And I have actually tried to make some gains by talking to clinic management, having them come into the clinic so they understand what these appointments are like. So they understand, think about like a pessary fitting, right? How long that can take, an hour and a half of time, right? And so if my allied health professional, my who happens to be a nurse practitioner, is working in the clinic with me and it takes her an hour and a half to do a procedure like this, I think that it's important for your clinic oversight environment to actually be able to see how that functions. So I've brought the clinic management in to follow us to make sure they understand that I go talk to a patient and then we get them ready for their exam. And then we do their exam in a very, type of way that is appropriate for that patient. And sometimes that takes a little extra time and gentle encouragement. And so it is not, it's a very easy exam in some instances. And then we allow them the dignity of getting dressed again before we come back in to have a conversation. So it's really a three-part endeavor. And I think helping them see that will help you allocate more time, because the one thing, I tell my clinic management a lot of things. And one of the things I tell them is when they can't fix the templates, and they say, oh, you can't change that template from a 15-minute to a 30-minute. I'm saying, you know what? About 50 years ago, we shot a man to the moon and brought him back alive. I think you can figure out how to change the time on my clinic template, right? So that always works. Not really, but it really helps them see what it takes to care for this patient population, and it makes a big difference. And you ask them, look, if this was your family member, how would you want me to do this appointment? Like, how do you want this to roll if it was your family member? And I've gotten actually them to see the perspective and change their minds by using that approach. So I encourage you to do that. You have to work with them and show them the value and the process of what you do.
Thank you very much. Very good answer. And I would also just add that, if you're spending time with the patients, something you should tell your practice is the bill will be appropriate, right? You're going to bill a level 4 visit more likely than not, or perhaps bill by time. And so there is remuneration for the practice for the level of effort you're putting in to care for the patient. There is a question, and maybe this is more appropriate for Gina, but open it up to the panel. How long can the Mirena IUD be used as a source of progesterone and hormone replacement therapy? So going a little bit outside of what we talked about, but is there any knowledge we can offer about this Mirena IUD as a source of progesterone and HRT, or Rachel as well, if you have an answer?
Yeah, and I'd like both of them to comment a little bit about systemic hormone therapy. And for many in the audience, including people that are just fundamental urologists, like, how do you manage that for people that are not facile and don't keep up with utilization of systemic therapy? What do we tell our patients, and where do we want them to be sent?
Yeah, so I'll start with that. Well, first of all, the Mirena, I want to make sure that it's clear that, Mirena IUD is not something that needs to be used when we're using local vaginal estrogen therapy. So that is not necessary. Some women who are on systemic estrogen for hormone replacement therapy will benefit from a progesterone loaded IUD such as Mirena. And so, the manufacturer has a insert in the packet that tells you approximately how long is typically between 5 to 6 years, 5 to 8 years, and then you have to replace it. But what I want to say about systemic hormone replacement is that is a very different thing than local vaginal estrogen. That I think what we've been talking about tonight and the data that is presented in the AUA guidelines is really laser focused on that. There is both benefit and risk of systemic hormone replacement therapy with estrogen alone, with estrogen and or progesterone. And I think again, the shared decision-making model definitely applies there. I don't do hormone replacement because talk about long visits. So I just can't do that and then also do urogynecology and reconstructive pelvic surgery. So we have North American Menopause Society certified menopause specialists in our group who I refer those patients to. They talk through not only hormone replacement with estrogen and or progesterone, but they also talk about alternatives depending on a patient's symptoms. So estrogen may not be the answer, or systemic hormone replacement may not be the answer depending on what her symptoms are. So that's a whole nother webinar and a whole nother, I think, discussion that we could have that could last a couple of hours. And there are experts, both primary care and gynecology experts that, are dedicating their practices to that.
Okay, very good. Rachel, anything to add to that before we move on to the next question?
I think it was a great comment. And all I will say to that is, as a urologist, doing systemic hormone therapy is one of the most joyful, wonderful, incredible things that I do, because so many of our patients have NFLM. They're not feeling like myself. And NFLM includes GSM. And I think we can't rely just on the 1,000 menopause certified clinicians that are out there that we must be teaching in the medical schools, in residency programs, and getting very loud about menopause in general, perimenopause, and hormone therapy. Because even though we don't have time in our clinics, our patients don't know that or care about that. And the influx of social media sort of talking about hormone therapy, Oprah's talking about it, celebrities are all talking about it. Drew Barrymore's talking about it. Halle Berry got diagnosed with herpes when she just had GSM. Okay. Halle Berry publicly talked about getting diagnosed with herpes when she just had GSM. So we as clinicians, if you take care of women, you must get comfortable sort of understanding the basics of menopause, perimenopause care, which includes I always say it's kind of like 5 things. It's systemic estrogen, systemic progesterone if you have a uterus, potentially testosterone, which has data behind it, vaginal hormones, and then the 5th one's the expert level for the vulvar vestibule, is really focusing on introital pain. But we have to get used to talking about this, because these patients are not going away. They're coming in droves, and the more we can arm you with the benefits often outweigh the risk, and the more we can talk about it, the better. So as a urologist, I can do this, which means our primary care docs definitely can do this. Our gynecologists definitely can do this. We have to create space in the healthcare system for more conversations around dignity and quality of life and systemic hormone therapy.
Thank you very much. Okay, want to bring a question to you, Dr. Flynn. So there's someone put into the chat, what is our assessment of potential legal repercussions to prescribing vaginal estrogen cream without a physical exam? Does the patient need to come back once a year for an annual pelvic floor exam, or you'll prescribe it once and then see them, through telemedicine for the next 3 years?
Let me just say, I don't practice medicine and worry about medical legal concerns maybe as much as most. I've been a professor for 25 years. I'm at the University of Colorado. I'm an expert in this field. I bring that level of confidence. So I think I'm hearing a lot of medical legal questions, which almost makes it sound like we're doing something fringe. I think if you explain to your patient well that this is mainstream, if you scan that QR that Melissa asked us earlier to scan and advocate, and let's get rid of the black box so we don't have this hangover. I think a lot of times people are using this medical legal argument as an excuse for not treating patients. I saw the same thing happen with pelvic floor mesh. And we all have convenient arguments to not maybe treat conditions because we're already treating problem A and B. We really don't want to get into problem C. With that said, if someone has done an exam in the last year, whether it's you, someone in your practice, one of your partners, one of your referring doctors, I think you have some pretty solid ground. I really encourage the exam. I say every day, I said it 3 times today, would you go to a cardiologist and expect them to not listen to your heart, right? It's part of what we do, and most people are okay with it, but I'm hearing some hesitancy. Maybe, Seth, do you hear this? A lot of medical legal concerning your practice. I remember this from the whole mesh controversy for 10 years, and it makes the hair stand up on my back. So I'm sorry if I'm a little edgy about it, but I'm really not that worried. This is mainstream stuff, and I think we have wonderful experts who've written the guidelines. We have the tools that we need to really engage the patients, and we need to lead in this space.
100%. And I echo everything you're saying. I work in a practice with a bunch of urologic oncologists and male-facing urologists, and they would be hesitant to write the word estrogen cream on a prescription, right? But that's why we have such amazing leaders like Gina, Melissa, Rachel with these AUA guidelines, with the opportunity to really use this as really as an opportunity to really espouse the greatness of this therapy with high yield, high benefit, very to minimal to no risk for all intents purposes.
Well, let's bring that up a little bit, Seth. Let's explore that a little bit. I'd like to ask the panel, there is minimal, and we understand this, very minimal risk to all the conditions that we've seen, but what kind of side effects do you ever see? What do patients tell you? What can our group here, all our attendees, counsel their patients when they say, well, because they're all going to ask, like, every pill I give you, I don't care what it is, you're going to get dry mouth and constipation. But what do you tell people about utilizing low dose vaginal estrogen?
I can go. So there's no medicine is without potential side effects. I think the most important one for vaginal estrogen is it takes a while to work. Is that you really, it's going to take 2 to 3 months, I think, to maximally acidify your tissue, which is what's going to help your microbiome and help you prevent UTIs. And so you have to kind of give that leeway of, you may get a UTI in the meantime because you may not be fully protected, and you could get a yeast infection because as the vagina acidifies, those little yeast cells like to kind of pop up. Treat the yeast infection. Don't stop the vaginal estrogen. Keep going, because once the microbiome is fully acidic, you get those lactobacilli in place, you're not going to see recurrent yeast typically, right? It's very rare that we see that. And if you do, go see a specialist, of course. When you need to phone a friend, phone a friend. Now, every once in a while, when I was first pregnant, I had breast tenderness. This was the first thing I noticed. And I ran to CVS to go get a pregnancy test, right? I didn't run to the mammogram to think, oh my God, I have breast cancer. And the breast has a lot of estrogen receptors in it. And so if you take an 85-year-old woman who has not had estrogen in her system for 30 years, if you give her even a 4 or 10 microgram insert, she may have a little bit of breast tenderness, in which case you say after just a couple of weeks, your levels, your tissue is going to get stronger, healthier, and your numbers are going to go right back down, and that breast tenderness is going to go away. We have the data to support us. And so those are the major things that I would say, but I'd be certainly happy to hear others. I'm always learning from everyone else.
Thank you, Melissa. In addition to what Rachel just brought up, some of the side effects of using moisturizers, right, and lubricants like vaginal discharge and yeast infections, you see those same things. So sometimes just the act of, using something that is going to alter your vaginal microbiome like estrogen does, like some of the moisturizers do, can just cause some of these issues. The other thing too is, sometimes the vaginal atrophy, the tissues are so inflamed and thin. Just the act of putting in the suppository to deliver the medication can cause vaginal bleeding and spotting. As long as that resolves shortly after, you do the application, it's not really a concern, because, it's hopefully trying to treat the problem that's making you bleed. And it's a very common reason for vaginal bleeding in postmenopausal older women.
So one thing I will say, because I see we're getting a lot of questions on this, is I agree completely, right? If you have a sunburn and you rub aloe on your sunburn, it hurts. It's going to soothe it, but it hurts. I mean, one thing that is magical here is buy a $7 mirror on Amazon. You don't need your clinic to buy it for you. Buy a $7 mirror on Amazon. I will Venmo you the money myself, and hold that mirror for the patient and show them the raw irritated tissue. You can even buy $10 pH paper on Amazon. And if your clinic won't buy it for you, they should buy it for you, by the way, but you can get narrowband pH paper for your clinic and show that they're actually using the therapy. Say, Miss Jones, your pH is 7.5. If we don't get it to 4.5, we can't fight these infections. And every time you get an infection, you get a little loopy. And so this is potentially going to increase your risk of needing to go to a nursing home, right? These are the comments, and you have to preempt. So for the burning, you have to preempt. Maybe you use a tablet insert and they can tolerate that. Maybe they prefer the estrogen cream. That's why you need the toolbox. Maybe the moisturizer is the first go, because it's going to help relax it a little bit so that you can use the estrogen itself. Meet your patient where they are, but make sure you give them what they need and that they understand the education. Because once they connect to the why, right? Most of our patients don't connect to their sepsis visit is an estrogen menopause problem. They don't connect it. But when you can show them and their families, right, it starts to make sense. I wish we could call vaginal estrogen something else because it's two bad words. The word vagina and the word estrogen apparently are both dirty words in our society. So if we could call it, bladder microbiome healing essential oils, then I think more people would potentially use it. So we have to get better at marketing this. So when your patients stop these products, it's because you didn't give the spiel hard enough. And I'd have it happen to me too. And it just means we have to work harder in our education of sort of connect to that why.
Excellent. Thank you very
And
much. Well, we have a comment, and then I'm going to lead off that comment to another question. So, NAMS is now referred to as the Menopause Society, and so thank you for that information. Now, taking that in mind, we've talked about the AUA guideline update on GSM, really great document. What are other society guidelines and society documents that our attendees should be looking out for that are high yield informative? Do any of you have other societies or documents you would reference in this category of care that might be helpful?
Oh, yeah. The American College of Obstetrics and Gynecology have multiple guidelines associated with hormone therapy, when to stop it, how to counsel, as well as vaginal estrogen therapy. So I would definitely visit the ACOG website and really type in search the word menopause, and then there'll be literally hundreds of guidelines, committee opinions, practice guidelines, and statements to help inform us all. Similar to these AUA guidelines, really informed by the relevant literature that was available at the time.
ACOG additionally has lots and lots of resources on other types of pelvic floor disorders that are often concomitant with the GSM. And so they have great guidelines regarding pelvic organ prolapse and pelvic floor dysfunction. And I know, Rachel, this is one of your specialties as well. Like, how do you treat pelvic floor dysfunction in the setting of GSM?
Yeah, no, it's a great question. And I was going to say the Menopause Society also they put out a practice guideline as well several years ago, where this new guideline updates that guideline. It really goes away from first line therapies being moisturizers and lubricants. And I think that's revolutionary that these new guidelines say, listen, it's a toolbox and we have to have a shared decision making with this toolbox. And the moisturizers and lubricants are amazing for dryness and pain with sex. We're not saying they're not amazing, but they don't prevent UTIs, which kill our patients. And so we can't wait around, for those, to fail before we prescribe these life-saving therapies. Now I forget what your question was that you just asked me because I went on a tangent.
No, that's perfect. It was about pelvic floor disorders.
Oh, yes.
What else do you do? There's often a concomitant problem with GSM. So it's the same patient population.
Yeah. So the key is kind of what's speaking to you the loudest in a way. And the reality is if the tissue is irritated, inflamed, if it's alkaline, if the microbiome is off, you're never going to get the pelvic floor to relax. Those people could do pelvic floor PT for years, and it's never going to fix the problem. If they have endometriosis, inside their bodies that's irritating their pelvic floor, again, PT may not fix the problem. That being said, if you can fix the hormonal problem, and we are challenged because the other thing Dr. Kaufman said that was so revolutionary that we just let it slip on by like it was fact was that GSM is not just a menopausal problem. And so we see GSM in many patient populations, in our young women on birth control pills, in our trans patients, in our breastfeeding or lactating patients, in our patients on spironolactone or disordered eating. When you play with hormones, there are consequences. And one of the major consequences is GSM and pelvic floor dysfunction. And so I think it's really important that you think about hormonal challenges. So if you have a 34-year-old who is getting these pelvic pain, you're doing all these cultures and they're all negative, but they've got pelvic pain, think hormones, right? Testosterone starts to drop in your 30s. So they may have perfectly normal cycles. Add that vaginal estrogen, add the DHEA, whichever one you want, because you will not hurt the young patient using these vaginal hormones. You will not hurt the patient. So I think the guideline does a really beautiful job of talking about engaging your pelvic floor physical therapist, engaging your sex therapist in really doing a multidisciplinary approach with these patients. But always think to yourself, is there something hormonal that is speaking to me? And I think you will never go wrong prescribing these vaginal hormones.
Right.
Very good. Okay, well, we've got another question here specific about some of the nuances of vaginal therapy, and so one of the attendees is asking if we can use intrarosa and UVFM together on different days. And so, what's our thought on that? Opening it up for the panel: intrarosa and UVFM in combination therapy and alternating days.
Yeah, I mean, we don't have data, but I don't think you'd hurt the person, right? Intrarosa is meant for daily use. I think again, the finding the perfect GSM strategy, like, that's when you get really, really in the weeds. And I don't know that there is one. And certainly we don't
Yeah.
have the data to back us up on that. Do I think using vaginal estrogen inserts twice a week and intrarosa on the off days would hurt the person? I don't think you'd hurt the person. Again, if a postmenopausal person bleeds, they get an ultrasound and a workup, whether they're on vaginal hormones or not. And so that would be my advice to the person. Is it over aggressive? Maybe. I don't know. We don't have the data to support that. Am I afraid? I'm not afraid.
Yeah.
Very good. Okay, so kind of a case presentation scenario: 22-year-old with chronic bothersome vaginal discharge, negative essentially for everything, no visible atrophy. Would you still give her estrogen cream just to see if it helps her? So essentially, vaginal pain, discomfort, discharge, odor, itch. No real other explanation. Is estrogen cream worth trying in that young age population?
Can I bet $120 million she's on a birth control pill?
Yeah. Or,
Good
she
thought.
may, I don't know what her menstrual history is, but if she's amenorrheic, if she has secondary amenorrhea, she's definitely somebody who needs some vaginal estrogen. And it really depends on what her tissues look like on exam as well. I agree with Rachel. It's not uncommon where I'll pre-treat my patients who I want to go to physical therapy for they have mild fascial pelvic pain. I'll pre-treat with vaginal estrogen because I know that therapy initially is going to be really uncomfortable for them. So that pre-treatment sometimes is really necessary to get started.
Yeah, and here's one place where I will say we need this guideline is so beautiful because it helps sets the stage for all the data that we need to gather. But there is no question that this young patient population would benefit and should be given these vaginal hormones. I think this is a beautiful space for vaginal DHEA because if we understand how birth control works, right? Oral birth control turns off the ovaries and it adds back synthetic progestin and synthetic estrogen, but no testosterone. And we just got done saying that this tissue has testosterone receptors in it. So the idea that there's no hormonal changes that can happen. So potentially adding estrogen may do the trick. DHEA may do the trick. I'd love to see more data on this. We tend to like hormonal IUDs because they don't stop ovulation as much. Again, I'm speaking to my urology audience here for all my gynecologists listening. I know you know this, but for my urology colleagues, we don't always think that there's a hormonal cause if they're not in menopause, but there are many reasons that they may do well with a hormonal approach. And what do you have to lose? You have nothing to lose here.
Now, Rachel, what do you have any strategies in specific? Because I've had some difficulty getting DHEA and Intrarosa approved from insurance. Are there any strategies or things that I can tell the place in my note that would be more likely for me to get an approval from insurance?
Yeah, I'd have to look at my team and sort of what our successes are. We have some templated prior auths that we have used. There is data on DHEA helping the vulvar vestibule. And I actually, I spend my Wednesdays with veterans. I work at the VA hospital, and I have been able to get it approved significantly for the veterans there because of that vestibule data that was published by Irwin Goldstein a couple years ago. So I think the insurance companies, we need to get loud about this, because the more data we have behind us, this intra-rosa thing is actually not a class. Like, it's like saying you have to try an anticholinergic before you try a beta agonist. That's not fair, because they're different mechanism of action. And why are you causing dementia when you can be giving safe therapies? And so DHEA, it's not vaginal estrogen. It's a completely separate mechanism of action, and we should be having it in the menu. But as we know, insurance companies are all evil in their own ways, and we're always challenged with how to navigate them.
Is there a gold standard age? I mean, when a patient walks into your office, for any of you, is there a trigger that all goes off automatically? This patient, I'm prescribing your estrogen cream. I mean, is it 55? Is it 60? Is it 65? Or it's really on an as come per patient basis?
I like that word, shared decision making again. I think you really do have to talk to your patient. I know there's not a magic age. What are her symptoms and what are you treating? So I don't look at my schedule and say, oh, I got a 60-year-old. I got 10 60-year-olds. That's 10 vaginal estrogen prescriptions I'm going to write. Not necessarily. I'm treating my patient. I'm treating her and her symptoms. And that may include vaginal estrogen. Often it does, but sometimes it doesn't.
But it also has to be outreach to other subspecialties, particularly in urology. Like, I want all my endourologists, when they're down there looking, when they're stenting somebody for their stone, they need to be evaluating. They need to be starting these types of therapies. It's really important to get this word out so everybody has opportunity to have treatment that could potentially benefit from it.
Melissa, if I may, I wanted to ask, maybe along similar lines, is there someone who may be too old, or maybe they missed the opportunity, too much time has gone by? Because that's where I sometimes see the most hesitation from patients, because they grew up in that era where they were told this is really bad and this is going to cause cancer, and don't do it. That's probably where the greatest hesitation is. Is there strategies maybe from the group on how to intervene, and maybe it's goes low and slow, and what's the strategy there?
No.
This is where the most quality of life that you can give a person in their 80s and 90s is that they're not waking up in the middle of the night, leaking, peeing on themselves, breaking a hip because they're getting up 6 times at night. The UTIs will kill and do kill all of those patients. And so that becomes the most important sort of like your job is to convince them that everything they knew was wrong. So find the language, find the shared decision making. Them saying no is such a shame. So whether it's such a lost opportunity, because they will die. All of our patients will die. And so the question is, but how will they live? And what do we want that life to look like? And do we want it to be from our thing? We don't want it to be from our thing.
Thank you, Rachel. Like, she and I think we're falling over each other to answer your question. So I specialize in geriatric gynecology. So I have, 50% of my patients are over the age of 80 every day in my clinic. And I have patients that I have on a rotating schedule every 3 months because they don't have the manual dexterity. They can't put the cream in. They can't put the tablets in. I have them come in every 3 months. I put their estring in. Their caretaker picks it up from the pharmacy. They come to my office, 5-minute visit. I pop it in for them, and then they go. And they do really, really well. I've really stopped some urinary tract infections in their tracts. People, as soon as they came off the antibiotics, the bug was still there. They were miserable. Definitely improved quality of life, improving their cognition in some cases. I've seen that. I've seen family members say that to me. So this is life-changing for that age group in particular.
Okay, well, I'm just going to step in because we got about 45 seconds left. So Melissa, want to summarize in 45 seconds? Any final thoughts or comments here?
Well, I'm just going to reflect everything that the panel said about this being a really transformational document that will change lives. It will save lives. And your engagement tonight is really fundamental to that. It is spreading not just estrogen cream, but spreading the word about this condition and the impact that we can all have to improve their quality of life and their quantity of life. So thanks everyone for their engagement.
And then lastly, of course, Brian, Gina, Melissa, Rachel, Seth, thank you so much for sharing your expertise and having this lively conversation. To all of you who are watching, you could have been at many places this past hour and a half. Thank you for choosing to be here with us. And this will conclude our Solve Wellness webinar. Have a great rest of your day. And with that, we are done.